Welcome to this explainer. I'm really glad you're joining us today because we're tackling something incredibly vital. We're going to completely demystify the esophageal cancer journey. Facing a cancer diagnosis or maybe supporting a loved one through it, it can honestly feel like you're walking into a giant maze completely blindfolded. But through the incredible source material we're unpacking today, which comes straight from the front lines of oncology, our goal is to take that blindfold off. By the end of this explainer, you're going to be armed with the clear, structured knowledge you need to make informed, life-protecting decisions right alongside your medical team. So, let's dive into this. Here is our quick roadmap for today. We are going to cover 1. The basics of the cancer, 2. Early symptoms and tests, 3. Progression and staging, 4. The 4 main treatments, 5. Post-op recovery and care, and finally 6. Making choices to protect life. Okay. Let's start right at the beginning with Section 1, the basics of esophageal cancer. To really get a grip on this, think of your esophagus as just a simple transit tube located right in the center of your body. It has absolutely zero digestive functions. It's literally just using gravity and muscle movement to push food from your throat down to your stomach. Now, cancer almost always starts on the very innermost surface, which is called the mucosa. But the danger escalates really rapidly as it invades the deeper submucosa, pushes into that thick outer muscle layer, and then eventually breaches the wall entirely to reach the surrounding lymph nodes. What's really fascinating in the source material is how this disease is heavily influenced by geography and lifestyle. So in Japan, for instance, we primarily see what's called squamous cell carcinoma, and that usually forms right in the middle or lower parts of the esophagus. But if we look at Western demographics, it's primarily adenocarcinoma. And why is that? Well, it's because the Western cases are heavily linked to chronic acid reflux, which just inflames that lower esophagus over time. Understanding your unique risks is definitely crucial, but here is a statistic that might actually shock you. A full 20% of patients actually have overlapping or concurrent cancers. These are most commonly found in the stomach, throat, or larynx. That's 1 in 5 people. This means when doctors are looking for esophageal cancer, they can't just put on blinders. Comprehensive initial testing of the entire upper digestive tract is absolutely vital. And that brings us right to Section 2. Early symptoms and tests. This is where the real tension of this disease lies. The early stages of esophageal cancer are dangerously silent. You feel totally fine, but as that tumor grows and starts blocking the transit tube, the symptoms become undeniable. We're talking about a feeling of food getting stuck, unexplained chest discomfort when you swallow, and severe, rapid weight loss just because eating becomes way too difficult. A really critical takeaway from our source here: if you have a hoarse voice or chest pain when swallowing, an ear, nose, and throat doctor might actually miss it because they can't see far enough down. You need a targeted endoscopy. Now, if you or a loved one are in this situation, you might be asking a very agonizing question. Why run so many exhaustive tests before actually starting treatment? When you know there's cancer, human instinct just screams, "Cut it out, right now." Why wait weeks for scans? Well, the doctors are actually on a meticulous fact-finding mission. Treating esophageal cancer is incredibly taxing on the human body. Doing the wrong, aggressive treatment on a cancer that's already spread too far, that actually does way more harm than good. So they use this whole arsenal of tests. The endoscopy lets them see the enemy directly and biopsy it. CT and MRI scans act like radar for deeper organ and lymph node spread. Then there's the PET scan, which brilliantly uses radioactive glucose to light up hyperactive cancer cells like a beacon anywhere in the body. The endoscopic ultrasound measures the precise depth of the tumor into those esophageal wall layers, and the barium swallow maps out the exact size and strictures of the tube. So they aren't delaying treatment, they're aiming the weapon. Once the medical team has all that data, we enter Section 3, progression and staging. You're going to hear a lot of medical jargon, and our goal is to translate it for you. The absolute most important acronym you'll hear is TNM. This is the classification system used worldwide to stage cancer. T stands for tumor depth, like how far through those esophageal wall layers has it grown. N is for node involvement. Has it reached the nearby lymph nodes? And M is for metastasis, meaning has it spread to distant organs like the liver or lungs? Your doctor calculates T, N, and M to give you a single clear stage number. Time is literally the ultimate enemy here. At 0 months, the tumor is happily confined to the surface mucosa. We call this stage 0, and it is highly treatable. But as months pass, maybe 6 to 12 months, that tumor invades the thick muscle layer and jumps to local lymph nodes, pushing you into stages 2 and 3. Left unchecked for roughly 2 years or more, the cancer eventually spreads through the bloodstream or lymphatic system to distant organs, and that creates a highly complex, advanced stage 4 scenario. All right, so how do we fight back? Let's move into section 4, the 4 main treatments. Oncologists basically have 4 primary tools in their arsenal, and they often combine them for maximum effect. First up is endoscopic resection, or ESD. This is pretty amazing. For very early stage 0 cancers, they go in with an endoscope and literally peel the cancer right off the mucosal lining. No major incisions. If it's more advanced, they turn to tool number 2, which is surgery. This is far more invasive. They might also deploy radiation therapy, blasting the tumor with high energy. And that's often combined with our 4th tool, chemotherapy, a systemic drug treatment used to hunt down cancer cells throughout your entire body. Now, if you're looking at surgery, I need to share an objective but really tough reality from our source material. Esophageal surgery is considered one of the most physically demanding surgical procedures a human body can undergo. To remove the diseased esophagus, surgeons literally have to pull your stomach or sometimes a piece of your colon all the way up into your chest or neck just to rebuild the digestive tract. It carries serious risks, including suture leaks, and historically carries a 2 to 3% mortality rate just from the operation itself. Because these treatments are so intense, they have to be perfectly matched to that TNM stage we talked about earlier. For stage 0, patients get that minimally invasive peeling. But for stages 2 and 3, hitting the tumor with chemotherapy first to shrink it down, and then following up with surgery yields the absolute best survival rates. Stage 4, unfortunately, is generally treated with systemic chemotherapy and palliative care to manage symptoms, because at that point the cancer has already spread way too widely for a localized surgery. Getting through the operation is a massive victory, which brings us to section 5, post-op recovery and care. We want to set realistic expectations here so patients and their families can properly prepare. The physical toll is severe. Because the surgery happens in the chest, right near the lungs, there is a very high risk of post-op pneumonia. Surgeons also have to navigate super delicately around the nerves controlling your vocal cords. If those are disturbed, it can cause extreme hoarseness. Patients will also face severe difficulties swallowing as that new tract heals, sometimes requiring metal stents to keep it open or even feeding tubes. In cases where the vocal cords actually have to be removed, patients might even need to learn to speak using specialized esophageal speech devices. And that is exactly why post-operative rehabilitation is an absolute mountain to climb, but it is so critical. Think about it. Simply removing the cancer is not a success if the patient can't eat or breathe properly afterward. Medical teams prioritize respiratory and swallowing rehab immediately. It requires a tremendous amount of hard work and willpower from the patient to rebuild those fundamental life functions. Let's bring this all together in section 6, choices to protect life. If you take away just one thing from this explainer today, please let it be this. The ultimate goal of treatment is not blindly attacking the disease at all costs. It's about tailoring the approach to match a patient's physical stamina and their personal life goals. For instance, if an 85-year-old patient with pre-existing conditions gets a stage 3 diagnosis, putting them through that massive, grueling surgery might completely destroy their remaining quality of life. For them, maybe a gentle chemotherapy or palliative radiation just to keep the airway open might actually be the bravest, most life-protecting choice available. I want to read this direct quote from the oncology source material because it is just so incredibly powerful. We must thoroughly understand what the most beneficial path is to protect the patient's entire life. Communicate your wishes clearly to your medical team. As a patient or as an advocate for someone you love, you can't just passively accept orders. You are the most important member of the shared decision-making team. You have to speak up about what you value most. So I want to leave you with a final thought to really ponder before you ever step foot into a doctor's office. When facing a highly complex, demanding medical journey like esophageal cancer, what does quality of life truly mean to you? Is it fighting for every single possible day, regardless of the physical cost? Or is it maximizing comfort, time with loved ones, and avoiding drastic physical changes? There are no right or wrong answers here. There's only the answer that is right for you. Thank you so much for joining me for this explainer. Stay curious, stay empowered, and please, take care of yourselves out there.